Our next speaker is Richard Melchior. Richard is the staff perfusionist at shop, and he got his perfusion from SUNY Upstate University, and later he got his master's from perfusion. He is very passionate about team dynamics, research, and patient care. He likes to spend time with family and taking kids for swimming. And one special thing about Richard is, for a longer time as my friend, is there any regular attendees for the AACP in this hall? American Academy meeting? So we very lovingly call him as Broom Broom. That means he started an event that makes us to visit every vendors without missing. So with extreme honor, I'm welcoming Broom Broom for this talk. Richard?
Thank you. Thank you, Isaac. Listen, we are 2.5 days into a wonderful conference so far. I've really enjoyed my time here. The talks have been amazing. Let's give our bottoms a rest. Everybody stand up real quick. Everybody stand up, give your bottoms a rest, and give yourself a round of applause again through 2.5 days of a wonderful conference. All right, there you go. So with my talk, everybody can sit down back down. With my talk, I'm actually going to go in a little bit of a different direction than what we've heard pretty much for the past 2.5 days, which were phenomenal talks, great content, scientific, talking about legends in the field. We're gonna talk about some mental and communication barriers that we deal with on a daily basis. But first off, I want to thank Richard Isaac and the rest of the Sanibel Symposium and the organizing committee for inviting me to speak about this topic today. Mental and communication aspects of our work environment intrigues me, and I really enjoy talking about it with fellow colleagues. For several years, I served as one of the safety officers at CHOP, and as a safety officer, I was responsible for help teaching our 4,000 plus employees about a safer culture for ourselves and especially our patients. I was able to curtail this safety program for our cardiac center as well, and teach it to all disciplines in a very small group setting between 20 and 30 people in each class. I put something together here that takes the lessons of that safety program and relates it to our clinical perfusion arena. So get ready. Be on the edge of your seats, okay? Because I might just call on you, which there's some that I know I'm going to call on, and get involved and possibly answer some questions for me, okay? All right. There are numerous perfusion serious safety events that could occur on a daily basis in our world, all right? There's air emboli, there's blood product conformation errors, there's bypass or MCS equipment mistakes or failures, miscommunication during a case, and the list goes on and on. There are two main contributors to perfusion serious safety events that I would like to discuss. The first is cognitive error. To overcome cognitive error, we will be discussing the concept of idea, which is a more in-depth concept of reflect and resolve, which I'm sure several of you have been exposed to in your workplace. The second area I'm going to touch upon is communication breakdown, and I'll introduce the concept of TLA, which helps overcome conflict resolution. Clinicians are at risk for cognitive error at any time, but they are especially at risk when they are fatigued, sleep deprived, depressed, resources are limited, and when you are truly experiencing cognitive overload. So let's dive into developing a way to overcoming cognitive error. In doing so, sit back, and I want you to think about thinking. In other words, what happens within your brain that you really do not control? Once you're able to recognize how your brain works, we will then look at ways to prompt yourself to overcome the potential for thinking errors. All right, I need some audience participation. What is this? Right away. I want somebody to yell out. Go. Air. Anything else it could be? No, it's air, right? It's very simple. You know, it's like boom, and unfortunately, we've all seen this in some regards. Unfortunately, maybe during a case, hopefully not, but afterwards, when we're taking care of our circuit, whatnot, boom, we see it. It's very easy, very recognizable, and there is no interpretation that needs to happen. All right, now what's going on with this? I want you to look at it a little bit closer, right? The circle is a little lighted out, but you can see some activity in there. But the arrows on the bottom, they're pointing to something in the oxygenator there. What is that? What is it? What? Air streaming. Could be a little bit of micro air. What else? Clot. Clot from what? Fibrin. Could be fibrin. What's the clot coming from? Low ACTs. What else? Could be, Bruce, what could this be? Maybe cold agglutinins. It might look like that. A little aggregation. Yeah, sure. Okay. Well, my point is there could be many other things. It could be several things, not just what you saw, which was air, which was very recognizable, right? So those are two examples that represent the two modes of thinking that we utilize. It's fast and slow. Fast, it uses pattern matching. It runs automatically at full capacity without conscious effort. It cannot be turned off. Generates solutions based on automatically finding a solution to fit the pattern of data, and it may stop once a solution is found. The other mode is slow thinking. It's a conscious effort of reasoning, logic, calculation, and mental simulation. It expends only enough energy to find a solution that seems reasonable, generates plausible explanations rather than proofs. It is important to understand that we need to use both modes in our clinical arena. We toggle back and forth between these types of thinking all the time, but both have advantages, but each of them can contribute to errors at the same time. There's an author by the name of Catherine Schultz that specializes in the concept of a person knowing if they are right or when they are wrong. She did a TED Talk highlighting the concept of not knowing when you are wrong, and she referenced Wile E. Coyote. All right, somebody, here we go. Where am I going to recognize a person? And you know what? Kareem. I know you didn't do it, but that's okay. Tell me about the Wile E. Coyote. What did he do back in the day? You remember Wile E. Coyote? You remember the cartoon? No. Who knows Wile E. Coyote? All right, Tristan, here we go. Tell me about Wile E. Coyote. What happened? Really? He was essentially dying all the time, right? Yeah. Jump around in front. Who was he chasing? Thank you. All right, so let me explain. All right, here we go. All right. He chases the Roadrunner all the time around the desert, right? Okay. And he would go up to the cliff, right? And he would go right off the cliff, right? And then when the Wile E. Coyote and the Roadrunner, they would get off the cliff, they would both look at each other. And the Wile E. Coyote, every single time, is like, oh, you know what? He's thinking, I finally caught you. I got you now. You're not going anywhere. But he doesn't realize that he ran off the cliff in the first place. And he is happy in his world of not knowing he is wrong. And then gravity kicks in and he thinks, oh no. As he crashes to the bottom of the valley, he did not feel wrong when he was wrong. Okay? Has anyone ever felt that way about a situation in life? Thinking that you are completely right, but unfortunately, you're wrong. And have you ever had this happen when taking care of a patient as well? This could happen to us when we are taking care of our patients. For example, we're on a care pathway for a patient. We are feeling sure and certain that we're doing the right thing for that particular patient. But being too sure and confident of that care pathway could lead us walking off a cliff and having no idea we are doing it. Being wrong with that care plan could make us feel just fine until it is too late. Most importantly, too late for the patient. Having cognitive bias can lead us into making thinking errors. It is useful to look at the breakdown of cognitive bias and understand the definition of each part. With looking at cognition, part of knowing something includes your perceptions, which in and of themselves can be biased. A bias is really a prejudice. And there are some types of bias that we really cannot help, and I'll be sharing some of them with you right now. All right, so there's 3 types of cognitive bias we're going to go over. And we see these very much in our workplace all the time. First, framing bias. It's the way information is presented or the way a question is posed can influence the conclusion we form. We see this all the time with report, with handoff, when taking over a case for one of our fellow perfusionists during bypass. Anchoring bias is a tendency to lock on an early feature of a presentation, form an impression, and not adjust initial impressions in light of later information. You are zoned in. You are keeping it right on, and you're not taking anything into play because you know what you think is what you think, and you're not caring about anything else. And the last is confirmation bias. It's a tendency to interpret data as supporting conclusion. Whatever information is coming, if it's going to support it, what I'm thinking, I'm going to take it, right? But then it's also a tendency to dismiss data that doesn't support a conclusion. If that information is coming in and doesn't comply with what I'm feeling, how I want to handle things, then you just totally dismiss it, okay? So those three we see a lot of, and you need to understand that you're seeing that, and how you handle that is something that is very important on how we take care of our patients. And so here are some other points to really think about. Although we may be confident in our conclusions, we can never be truly certain. Critical thinking is an error-prone process. We can't possibly know what data might be missing, what answers lie outside of our experience set, or what explanations await discovery. All impressions, conclusions, and diagnoses are at best hypotheses drawn from the data we consider. If our thinking generates hypotheses, then we should consider our actions and treatments as experiments through which we can assess the validity of our hypotheses. Once again, diagnoses, impressions, and conclusions should be considered working hypotheses. So let's go over the concept of idea real quick. All right, the I stands for identify assumptions. How do I reach my conclusion? All right. The second is for D. Don't assume I'm correct. What would change your mind? What information could come in that might change your mind about a situation? Third is the E. Explore expectations. What should I expect to see if I am right, if I'm not right, if I'm wrong, what should I be seeing? And last is to assess alternatives. If things aren't working out properly, what's your plan B? What is your exit strategy? How are you going to handle the situation if the way you're thinking about something is not correct? So let's use idea with an example in our world, all right? I'll read it here. So it's a 60-year-old male. It's a 100-kilo patient. It's an AVR, MVR procedure. After the case is done, everything's looking great, no worries. And then the patient starts to deteriorate, and bypass needs to be reinitiated emergently. Protamine had already been given previously, but the reheparinization of the patient had supposedly occurred by anesthesia. They said they gave it. The perfusionist was told by the surgeon, go back on bypass, right? Yeah, okay. Very urgently, go back on bypass. After 10 minutes, the venous return in the venous reservoir seems to be impeded for some reason. Let's use I, identify assumptions. What is causing this? Could it be the norm, right? Could it be venous cannula position, volume issues, vacuum source might be something obvious is happening that you see on a daily basis possibly, and it's easy to understand. But don't assume that you're correct about that. Is there anything, other information that would change your mind? Could it be something else? If all other issues seem to be okay, dare I say it, could there be clot in your venous reservoir? E, explore expectations. After testing each variable, the issue is still there, bring that other information in, arterial line pressure is going up, all right? And then in your mind, you're like, really, is this happening? Okay, that's a little PTSD for me too, come on. And then last is assess alternatives. Yes, your circuit is clotting off, and plan B, you need to change that circuit and find out how you're gonna handle that, okay? Any questions on that? No? Okay. There are many ways to show that you are practicing with a questioning attitude. There's three that I want to talk about right now. And I'm sure several of us, many of us, all of us handle this in the same way, I hope. If you have a visceral gut feeling that something is wrong, you're willing to say, you know what? Stop. I have a concern about what's going on in this operating room. I'm willing to change it and handle it, right? Another one is that, we use a lot in our practice is what's happening over the certain amount of time, right? Over a certain amount of hours, what's changed, what's been altered, and then we backtrack, finding out what's going on, and you're constantly using analytical thinking to find out, you know what, something's going on, we need to change something to make it better. And the last one is, I do this with my colleague all the time, and I hope she feels the same way, that she will, we both, and all of us hopefully will do this, is that if there's something not looking right during our case, you bring somebody else in to take a look at your circuit, take a look at the situation, and feel that it's okay to do that. That is being truly acting as safe as possible and understanding that you're trying to get to the root of it and being open to somebody else's critique and or understanding of the situation. All of this is more effective when thinking is done as a team as well. Thinking out loud and thinking as a team is a process of collective critical thinking. Well, so let's now get into communication, how vital proper communication is with regards to maintaining a safe environment in our workplace. One of the most effective ways to improve safety culture and prevent injuries is to optimize safety-related communication throughout an organization. Unfortunately, employees often fail to speak up when they observe risky behaviors, even when they know they should. So I have an example here and a little story for you. So like I'd mentioned before, I taught this safety class over and over and over and over again to many people within CHOP. But what was really nice is that I was able to curtail this course to the CTOR staff of all disciplines. And we would take about 20 to 30 people every single one of these CTOR classes and bring them in, and of all disciplines. So at one class, I had one of the most well-known, respected surgeons that possibly might have been on a presentation just recently here. That phenomenal surgeon, great man, but quite frankly, he could be a little intimidating in the operating room. And there was a nurse that had been with us for about 5 years so far, but she had a little bit more of a timid personality. She didn't feel comfortable talking with this surgeon during cases. And it was an open dialogue type of class. And everybody was willing, closed door, open dialogue. So everybody felt comfortable talking with each other. This nurse highlighted during this class and looked right at the surgeon and said, "Sir, I really don't feel comfortable talking with you during cases. I feel like I am not worthy of discussing things with you, and I just am there to do the best I possibly can, but I just don't feel like I can question you at any time." And that surgeon looked right back at her and said, and I was shocked, I was floored when this surgeon said this. He said, "That is the complete opposite of the way you are supposed to be in my operating room." And I was completely floored he said that, because it's never been like that in the operating room with him, but it dawned, I think, with him during that class that that is the way he's supposed to be. So that interaction happened. She felt comfortable about that. She's like, wow. She came away from that class and she said, "Rich, that was really great." Now, fast forward a week. I'm doing a case with this surgeon and this nurse. We're in the OR. We're doing a AVR with a valve, like a valve conduit. He's sewing the conduit on this brand new valve that had just come out. And he's doing his thing, and everybody's just, doing their thing as well. And she realizes that he's doing something wrong. She realized that he was actually sewing that valve in upside down, because it was new. It was something new to him. He didn't realize. And she had been taught during when the rep was there, this is the way it's supposed to look. Anyway, she highlights to him and says, I'm not going to say his name, but "Sir, I believe there's something wrong here." And he looked at her and questioned, like, what are you talking about? "Sir, that valve is upside down. You need to change that right now." And he looked at her and said, "Wow, thank you. That would have been obviously a major serious safety event that could have went down the wrong pathway, and we could have been in what creek to later on." And he turned to her and again said, "Thank you for doing that." And then she looked at me over the drapes. He looked at me with his light, and we all kind of looked at each other, and I just did this. That was a great moment. And I will say, and I'm not sure if my colleague Kelly remembers that time period, but there was a major change that happened, even with him being in our OR for another 10 years or so, or 6 years or so after that our environment changed almost like overnight when we started doing these classes. And that's how important it is to have this open dialogue and open communication style. So let's move on here. We'd like to use a linear communication model and talk about this concept of proper communication in the cardiac OR. The result of this model is what we hope to achieve with all disciplines, especially the surgeon. Let's take, for example, the interaction between the surgeon and a perfusionist with the command and response technique. The surgeon, being the source, would communicate a command like turn the vent on, which would then be received by the perfusionist. Perfusionist turns the vent on. Then the roles reverse. The perfusionist is now the source when responding back to the surgeon and saying the vent is on. The surgeon heard the perfusionist, understands the response, and is satisfied. Boom. That is an example of a successful basic communication exchange. We hope to have that every single time. Does everybody have that every single time? Ah, there we go. That's what I'm talking about. All right. So the problem arises when there is a communication breakdown, being a misunderstanding, not hearing of a request. If the surgeon does not say to turn the vent on, or the perfusionist does not hear the surgeon say turn the vent on, or the perfusionist does not hear the surgeon say turn the vent on, then the rest of the command and response technique fails. If this miscommunication occurred, the vent is not turned on and the cross clamp has been removed, air would still be in the heart, and as all of us know, that air would travel to the patient and could cause a serious safety event. There are several communication styles, right? We all understand this to a certain extent. The three styles that could cause conflict within our working environment are people that are passive, the passive-aggressive, and the individuals that are essentially just too aggressive. Raise your hand if you have any of these styles on your team right now. Yeah? Yeah. Makes for a little bit of an awkward working environment, doesn't it? Right? You would hope that's not the case. About 1/3 of serious safety events are associated with ineffective verbal challenges. All right? And so what is an ineffective verbal challenge? It's somewhere along the way with an interaction, there was an attempt to communicate that failed. It may be that a person was not heard. It may be that a person was not open to someone else's opinion. Perhaps someone was too certain that they were right. Hint and hope is indirect, while the opposite is being very clear and direct. We all know that we cannot just hint and hope in our environment. Sometimes it is more difficult to be direct, and we fall back on hint and hope, but we can't do that. The best method to overcome any issues with communication is to be clear and direct. All right, so this is an exercise we're going to have a little fun. All right, you're at the zoo. Your child is talking about his favorite animal, and he is not sure what it is called, but describes it. It's gray, has leathery skin, and tusks. Audience participation, what is it? Walrus. Okay, walrus. What else? Rhinoceros. What else? Elephant. Perfect. Exactly what I wanted you to say. So, now, we'll bring it into the perfusion and the cardiac surgical environment in a second, but where you live, okay, may predetermine what you assume the answer will be. For example, if you ask someone from Alaska, they may quickly say, well, you just said it. Oh, get out of here. So they would say from Alaska, they would say walrus. Okay. All right. And if you ask someone from Africa or India, they may say elephant, right? Okay, very good. And this is what is known as availability bias. Okay. Choosing something based on what you have been exposed to. A perfusionist background or experience could be very different from another colleague, right? And this difference can occur with every other discipline in a cardiac center. Therefore, the mindset of handling a particular care plan might be very different from one individual to another. And with that being said, conflict can arise from that disagreement. How each person handles those differences and or conflict with that care plan is something that could cause a disruption in the workplace. I see that 5. Okay, I got you. All right. Reaching agreement requires that we resolve our disagreements and differences by communicating openly. That includes these elements that can be used interchangeably. Tell your thoughts to share your thinking. Listen actively to avoid thinking errors, and ask questions to gain clarity and build understanding. The ultimate goal is to reach an agreement to proceed in a way that all parties think is reasonable, and understanding that There are arrows that go back and forth here. You could start with tell, you could start with ask, you can start with listen and go around in a circle, in the triangle, any which way. You can handle it in different ways, but understand that root is there to allow you to have open communication. Some key time periods that TLA can help during our clinical day are time periods during bypass and managing patients in ICU. Also, if you're dealing with issues with administration, this model can help with overcoming those difficult conversations and barriers you may experience. We want to reduce cognitive error as much as possible. Always take in the whole picture before making a decision and utilize the concept of idea as often as you can. Try to always have a level of open communication with colleagues, and the combination of these concepts could truly make your working environment safer for yourself, but especially your patient. Thank you very much for your time. I appreciate it.